And this is the Healthcare Policy and Research Panel for the Center for the Business of Health Career Networks. We really thank you for joining us tonight. The career networks in our panels are a part of the UNC Center for the Business of Health's new, not so new anymore, a couple of years now, but our Career Networks program. And the Career Networks program is a constellation of resources meant to educate and create community around the continuously evolving healthcare ecosystem. And I think that's why many of you are probably here tonight to kind of learn what's new and to learn a little bit about what people are doing out there in the healthcare policy and research ecosystem. You can explore the Center for the Business of Health's Career Network platform via the URL that I'm going to paste into the chat. For tonight's panel, we ask that you turn your video on if you can. Please do remember to mute though your microphone unless you're unmuting to ask a question, because sometimes the background noise is a bit much. If you have any questions prior to actually, if you have any questions during the panel, please feel free to raise your digital hand. I'll stop every few moderator questions, or we'll just kind of find little breaks. We'll open it up to everybody in the audience to go ahead and ask those questions. Again, if you are not allowed to speak, sometimes people are at work or something of that sort, feel free to go ahead and put that in the chat, and I am sending out that link right now. So again, tonight's conversation will be on the experiences of the panel in the areas of healthcare policy and research. I'm Susanne Killian. I'm the Associate Director with the Center for the Business of Health. Erin Leach, our program manager, is diligently working behind the scenes. She's making sure everything is working well. Joining me for this discussion tonight, we have Amy Gandhi, who is the Staff Vice President of Medicaid Compliance for the East Region with Elevance Health. We have Lindsey Hanes-Maslow, Associate Professor, Health Policy and Management with the UNC Gillings School of Global Public Health, and Mike Rawaan, Founder and Principal Consultant with Covalence Healthcare Consulting, and I'm hoping I pronounced everybody's companies correctly tonight. Again, we will be asking a few questions, but we're going to start off by asking our panelists to just introduce themselves and tell a little bit about their experience, education, and just tidbits to get you interested, and then we'll start with some of our questions. So let's say we'll go Amy, Mike, and Lindsey. So Amy, please kick us off.
Okay. Hi, everyone. My name is Amy Gandhi. I live in Northern Virginia. I'm an attorney by background. I have spent most of my career in healthcare, not a straight line, and now work in the Medicaid space for Elevance Health, doing Medicaid compliance work.
Terrific. Thank you. Mike?
Sorry, couldn't find the mute button. I'm Mike Rawaan. Hello, everyone. UNC grad, MBA class of 12. And as mentioned, I am the founder and principal consultant at Covalence Health. My career path started actually in technology. I was a technology guy originally by training, and was on that side of the fence for about 4 years before transitioning over into product development and strategy. And my career has largely been sort of in that product development, growth strategy, and I have worked pretty much across all segments of healthcare, pretty diverse background, working with healthcare providers, healthcare payers, services organizations, technology, obviously, benefits management. So kind of seeing the industry from a 360 point of view, if you will. And now I've been doing consulting, and as a consultant, as a consulting firm, we work in all of those segments. Our clients are from each of those segments that I've mentioned. Pleased to be here, and looking forward to the discussion.
Great. Thanks, Mike. And Lindsey?
Hi, I'm Lindsey Hanes-Maslow. I'm an associate professor in health policy and management. I am a three-time UNC grad, so I apologize to anybody out there who went to other schools. Yes, I had my BSPH in 2008, my MHA in 2010, and then my PhD in health policy in 2014, and then moved to the DC area. And most of what I'll talk about tonight is actually merging different intersections. So I really focus on the intersection of where food policy and agricultural policy meets health policy, and then how you work across different federal agencies. And then I'll share more later, but hopefully that will pique a little bit of your interest of how do you get people to talk to each other and speak the same language when they don't. So I'm looking forward to this. Thank you for having me.
Terrific. Thank you so much for the great introductions. And we will start with our first question. Again, you can popcorn around. Everybody doesn't have to answer every question, but anybody who wants to take the first answer. Our first question is, please define your current role and what steps did you take to land in your current career?
I'll go ahead and start, Suzanne. My current role, and probably most of the roles I've sort of fallen into. I graduated law school right after 9/11 in 2002. I'm originally from New Jersey and graduated from Seton Hall. It was a tough time. It was a tough market. And I worked for the courthouse for a while. I went to a law firm and I realized it wasn't for me. Divorcing people at 25 years old was not really the career path I was looking for. And I started thinking about where could I use my skill sets from law school? How do I use them? And in what industry do I use them? That's sort of going to take me down a career path. And I thought about IT and healthcare and started applying everywhere. And this is, right when the internet is out, right? You're still looking, in newspapers, you're looking in magazines, you're talking to people. And I fell into a health plan and started looking at contracts. And from there was able to do some contract negotiations. And I was then moving to DC, and a hospital system hired me and asked me to do contract negotiations on the other side. And I started looking at compliance. I think that's sort of when, Sarbanes-Oxley had just come out a few years before that, and compliance was starting to get big. And I'm like, oh, I could do this. And started looking at, I really like the health plan. Maybe I'll go back to a health plan and do compliance work, and worked out. But then, we were acquired, and I acquired all these other jobs with it. And then I went to a startup, and like Mike said, sort of turns and twists have taken my journey. It has not been a straight line. And I went to a startup that was 5 years old. When I got there, it is now 10 years old, or maybe 11 years old. It had just gone public, and it was amazing, the opportunities. It was amazing how out of control it was. But I was like, oh, I could do compliance work. And, 2 years later, I was like, well, why don't we do this? And they were like, oh, great, go build it. And then 2 years later, I was like, we don't do this really well. They were like, wonderful, why don't you go do that? So some great opportunities until I was laid off with the change in sort of the business structure last year. Had the opportunity to do some consulting work, and then said, I kind of miss the compliance space, and I always wanted to go back to the health plan. And started looking around and started applying and started interviewing. Had offers in doing a couple of different things. The last job that I had, I was doing vendor management and negotiating contracts again. And this job literally fell in my lap. Was it what I was looking for initially? Probably not. I was also told by recruiters that I had been out of healthcare for too long. So I think that's sort of really important to note, that there were people that were telling me, oh no, you've been away from it too long, you can't do it again. And then I have the executive recruiter telling me, oh my God, you're the perfect fit for a job I didn't even apply for. So it is not always a straight line. I feel like I take the yellow brick road, but I've sort of found my way. And the healthcare space is so big and so diverse. I don't know what the future will bring.
Actually, I love that you had similar advice, or maybe not so helpful advice, but I will say I've lived in 7 states. I went to 4 elementary schools, 2 middle schools, and 2 high schools. So the only home I ever even knew was UNC Chapel Hill. And I remember arriving there and knowing that I wanted to come back there. So it was going to be a circle. I didn't know where I was going to go along the circle. And when I graduated with a PhD and said I was going to go to DC and do advocacy work and do policy work, I had a lot of questions. I had a lot of people saying, if you want to return to academia, you won't get a job. You'll be seen as an advocate. You won't see as someone who's objective. You're going to be seen as biased or pushy, or you'll have all these labels. And I said, I'll accept that, concern, but I want to go to DC. And so I worked for an advocacy organization on food systems and health policy, and really tried to see, and I worked with both the U.S. Department of Agriculture and HHS, and how do we focus on looking at the connection between how food and health are so connected and intertwined, but also the fact that we speak, as I mentioned, different languages, we operate differently, we're on a different legislation cycle, we're funded differently. It's amazing how much overlap there is, but how completely distinct they are. But yeah, I will say that after I worked in DC for a few years, I came back to North Carolina, but worked at North Carolina State University and oversaw a statewide nutrition education program. And then was during the pandemic, I was still doing a lot of field work. So being out in the communities, talking with communities, and realized that there was a very, very concerning mistrust, lack of trust, distrust in also just say health science, research, data, anything that had to do with everything I spending 10 years in school doing. And I heard concerns of not, just, I don't understand this, but it was more of, I don't trust what people are telling me. And that's when I said, I'm going to start looking back to public health and realizing that we have to educate the next generation, because when I graduated, and I'm sure when Amy and Mike graduated, the space was a little bit more open to health scientists or folks that could do this work. Now, if you say you work in healthcare, you maybe will get an eye raise. And what do you do exactly? So I'm now back at UNC in health policy and management, teaching leadership and management classes, teaching business planning classes, but mostly also just trying to show students that you can, as Amy said, there's no clear path. That you can definitely make that an interview answer, and that's great to have it. But if you could say, I knew exactly what I was going to do and how I was going to do it, I probably wouldn't believe that answer, but you could tell me a really, really good story. But I'll hand this over to Mike. But yeah, I'll just say I came full circle and had planned to come full circle, just didn't know when that was going to happen or how.
I think the key message, and all 3 of us here, is that the orthodox career path is no longer a thing. And I think I'm a Gen Xer. If my generation and generations beyond me are going to experience a whole different journey in terms of figuring out where you kind of belong, what do you want to do when you grow up, to answer the age-old question. I started at technology. I said, the reason I went technology, this was the late 90s, and I got into community college, and every community college recruiter or admissions person told me, you want to get into technology. And I got into communication technology because that was my job in the Marine Corps. So it was an easy transition for me. And I got a 2-year degree. I got out, and that's when the .com bubble bursted. And so all the technology jobs were gone. And I was left saying, well, now what? So as I was working in technology jobs, one of the things that I noticed very, very clearly and early on was technology was trying to do too much to solve problems. And I thought a lot of these problems just aren't technology problems to be solved. And that's part of the reason I transitioned into product management and strategy, because I felt the need that there needs to be an underlying strategy that dictates what technology needs to do to support the solution. And that led me, coincidentally, it was a sort of a timing coincidence. It led me into healthcare, and I started working for a large hospital system at the time. And my journey in healthcare kind of started there. And what I discovered was that there's a lot broken, and there still is, right? This was 17, 18 years ago, but there's still a lot broken. And for me, I'm the type of person that doesn't run away from challenges, right? Curiosity killed the cat, but this cat's still alive because I'm attracted to complex challenges, and there's quite a few of them in healthcare. And my objective was to really try to learn as much about healthcare as I can. And one of the reasons I kind of jumped from one side of the industry to the next was I wanted to get that experience and perspective. And looking back now, some of it was very, very, some of it was planned, some of it was just, I got lucky and very serendipitous. So as I think about that, I think I've been pretty fortunate to have that diverse experience and be able to look at things from multiple perspectives, because as you start to look at how policies are formed, oftentimes there is heavy influence from one side and sometimes the other side. And it's very important to think about what is the implications, the ramification across the board on some of those policies. So as a consultant, one of the things that we do in our firm is we work with organizations to implement policies or implement new programs, such as the Medicare value-based care programs. And it becomes very, very important for us to understand, how does this impact all of the stakeholders, and what do we need to do to get all of the stakeholders to come on board? And that requires sometimes tweaking the pitch a little bit, because you're talking to someone on the payer side versus someone on the provider side that may be looking at things quite differently and sometimes in the opposite way. And so understanding the dynamics of the industry, the complexity, and also understanding what was sort of the source of the policy and what was the intent, it becomes very, very important in its application and implementation of it.
Terrific. Thank you. Mike, like you, I was trying to find my unmute. But these were all just such wonderful explanations of roles. And two things stuck out to me, and maybe the audience as well, that you're going to have times of missed decisions or bad advice that you, in retrospect, look at that. But the thing is that being flexible and using those as experiences, allowing you to move along the road and keep going, and don't let those trip you up. Secondly, the fact of the times change, the economy changes. So you have to be able to change as well. And that's what all of our panelists have done. But there's one good thing, is that just know what you enjoy, know the skills you like to use, and then just kind of wayfind. Think, I might take a lot of turns. I love that circuitous. I didn't have a straight path. I'm still trying to find the person with the straight path. Often we get stuck in that idea. And as you can see, these wonderful roles that the folks have here may not be their last even. But they got there, and they're going to keep moving forward in that manner. So thank you so much. Those were fantastic answers. So I'm going to go ahead and first off, I'm going to open it up. We have a really large group tonight, so I am going to open it up. Usually I'll do 2 questions, but I think that this might be great to just kind of see if anybody has a quick question at this point in time hearing so far. And again, I think if you raise your digital hand, you'll kind of slide into my view. And if not, we can surely kind of move on. And in addition, we have a couple of topics that came in with the registrations that I'll go ahead and add as we move along as well. My second question would be, what skills, abilities, and experiences do you use regularly or most often in your career? And did any of those surprise you? Like, oh, wait a second, I didn't know that in this role, I'd be doing so much of this.
Susanne, I'll start off. It's what I have said is everything is negotiable. It is true, and a lot of people will say, "Oh no, everything's not negotiable," and you'd be surprised that somebody may say no, but people will try it, and I say, why not try? I try to take, people are coming at me with questions all the time, right? And so I always say, I'm trying to get to yes, right? Like, I will do my very best. In my role, my job is to ensure that we are compliant with Medicaid regulations. I oversee 16 of the 26 markets that Elevance owns, and I've got about 75 people under me. People are coming at me, well, Amy, can we do this? And I'm like, I don't know. It depends on the state. Amy, can we do this? I don't know. Maybe. I'm like, what do you need? Tell me what's your end goal? What are you trying to get to? Instead of asking me, can I write this here? Tell me, Amy, we are trying to provide information to our healthcare members to let them know about the flu shot. Those are two different questions. And so working on using my negotiation skills, and then I think about the really simple things we learned from childhood, like kindness, being respectful, being thoughtful, letting other people speak, remembering that, you may be sort of on top of the world today. I had a CEO once who fell off the ladder and just kept falling. Don't know where she even is today. So remember that you may need help on your way up, but you may also need help on your way down. Asking for help, asking for feedback, always having a regular feedback circle, I think are huge, huge things that I don't know that I would have thought about 15 years ago. I'm like, of course somebody will tell me if I'm doing something wrong. No, they might not, or they'll wait until your review, and then they'll hold it against you, or they'll talk about it in a meeting, or they'll say, oh, don't give this project to so-and-so. They did a horrible job on the last project. Ask for feedback, If you're doing your first presentation, your third presentation, if it's the first time you're presenting to a leadership group, if you're especially nervous, ask for feedback. I think there's some really basic things that we could be doing to make us a better partner, whether it be to our students, to our community, to the people we work with, to our clients, to our bosses, to our families, to our friends. I think COVID's brought everybody together from different places. But there's some really basic things that I think people have lost along the way. I don't know, Mike, what do you think?
I think you hit it on the head, actually. I mean, I want to expand on the theme that you were talking about in terms of just some of those childhood skills. I think empathy is another one. And that's one of the things that I have learned throughout my career, and learned to consciously think about being empathetic. And that's something that, for some folks, it may come naturally. For others, it's easy for us to kind of get lost in our own world, in our own role and responsibilities, and fail to kind of look outside and see things from others' perspectives. And I think that's very, very important. And I think that allows you to gain some leverage with folks and have some social equity with folks. And as Amy mentioned, it's very important that you have a support group, that you have a network that can give you feedback, that can help lift you up when you're down, but also support you as you're on your way up. So I think those things are very, very important. Those soft skills, I think, especially for MBA students, for myself, they seem kind of like a waste of time, but you have to understand that they're a thing, they're real, and they're very, very beneficial. So strongly recommend exercising empathy, reminding yourself, and also communication. And communicate the basic stuff, right? Understand the audience, read the room before you open your mouth. Don't open your mouth if you don't have to. That's something I used to do a lot when I was coming up. I thought, the more you speak, the smarter you sound. Well, it depends on what you're saying. And so those are some of the things that are just on the soft skills side that I would recommend. But, since we're talking to folks in the academic environment, I want to kind of tie this to some of the classes that I had as an MBA student. And when I think about skills, a couple of things that while I was in class, I was kind of scratching my head, like, how would I use this in the real world? One of them was statistics, and oh my God, I use that on a daily basis. So understand your bell curves. Those are, especially when you think about public health and policy, there is so much statistics involved because you're looking at a population level and you are having to basically understand what are the ramifications and be able to quantify things. And you need to have those statistic skills there. The other was economics. And economics, I'm a huge fan. I consider myself an economist by hobby. Yes, I'm that interesting. And I really didn't see an opportunity for me to use things like game theory and the corporate world, because I was thinking I'm never going to be in a sales role where I have to kind of use that. But as Amy mentioned, we're always negotiating, and game theory becomes very, very important. And that kind of goes along with empathy, understanding the other side and understanding what you need to give them in order to get what you want. And this ties to another concept, and I'm going to make a book recommendation here. There's a book by Ben Horowitz, from Horowitz and Reason, who were, the Netscape guys. And one of the things that he mentions in there is this idea of reciprocity, and that it's such a powerful tool when it comes to influencing and negotiating. So, and that goes back to empathy, understanding the others and understanding what they want, what they need, being able to deliver that to them so you can get what you want in that negotiating process.
Yeah, I love this theme here, and I'll kind of try to tie this all together because I'm going to have some overlapping themes, but this is not my quote. I'm taking it from someone else, but you never tell a story without a statistic, and you never show a statistic without a story. That's what DC taught me, and that's what a communications and an outreach team will teach you when they're teaching you how to communicate with policymakers on all sides of the aisle, not just one side. But being able to tailor that communication, I think I did not realize the level of communication I was going to be giving. And so even talking about negotiation, that is communication. That's a communication strategy. It's, you know what, I want 5 things. I'm willing to only take 3, and I'm going to let somebody else have other wins. I also think with empathy, you can show that in communication, either verbally or non-verbally. And I will say that is something I am glad that Mike, you and I think Amy, you might have mentioned or touched on it a bit as well. But those things I thought, as someone who's getting a PhD and MHA, I said, oh, I'm just going to be doing research. That's it. I'm not going to talk to anybody but my computer, or I might yell at it some. But I ended up managing people, managing a team. And again, with everything, it was always about how do you find those small connections and those soft skills. I still write thank you notes. I know this is silly, but I've gone to people's offices when I've not met them in person, and I see my thank you note on their desk. And it's those tiny things where it took, 10 minutes for me to write a thank you note to send it. But it's the soft touches, those soft skills that I think people may undervalue, but when you're the person receiving it, I keep all my thank you notes, especially on days where I feel like, wow, this was a horrible day and I didn't accomplish anything. What am I doing with my life? Or am I making progress? But I think that communication, absolutely. And this will kind of tie into this as well. But if you manage a team, or even work with peers, I would say human resources. I know that's probably a class you're taking, you are in. I cannot tell you how much human resources I had to utilize so quickly, so fast, just because I realized that human resources, again, it's about people and communication, and oftentimes miscommunication. But I do appreciate, again, the idea that Mike also brought it in, just this idea of messaging. How do you start a conversation with just starting a conversation? Because there are certain phrases and words where you can try to start a conversation and you end it immediately. And I don't think that's the purpose or goal of anybody, to completely end the conversation with the opening sentence. So I would definitely encourage, and I have colleagues of mine that we try to say, okay, let's play devil's advocate. Or if I'm, I have this viewpoint, how do I approach this issue? And am I going to discuss, return on investment? Is that my first talking point? Or am I going to talk about this is important for the public's health? Healthcare is a right, XYZ. But again, knowing your audience, knowing what they've done before, how they might receive that message, and then tailor that message so you can actually enter a conversation.
Absolutely terrific advice. I have so many nuggets that I wrote down. And also, I hope you all are tracking in the chat that Mike has been putting in some really great books to go ahead and access there as well. This may lead really well. We had a question in the chat, and this is, what advice do you have for clinicians who would like to transition to a more policy-focused career? And I think that kind of feeds into what you all were talking about, skills and kind of knowing audiences, et cetera. So I'd love to hear from you all.
I actually used to do policy trainings and workshops for physicians, and I was always amazed that they were terrified to talk to their legislature or their elected official. And I said, why are you afraid? Like, you literally are a pediatric cardiologist, you are a primary care physician. What are you afraid about? I said, this is probably going to be a staffer who's 25 years old. But I think that physicians and providers are amazing, again, storytellers. You have the voice of the patient, and you have the ability to elevate that voice of your patient. And again, what policymakers like, some definitely prefer the numbers and where are you backing this up and how are we going to pay for this? You want 10 million or do you want 10 billion? And what do I get for that? But I think bringing in that human aspect to it and saying, I have seen this, I have witnessed this, I have been told this, and I will tell you, my patients today can't tell you this in person, is a very, very powerful aspect. I think physicians, providers, I think anybody with some type of dual degree or aspect, again, a law degree combined with an MBA, having a tech background, I think those are all just better ways that you can communicate, and you're able to give a side of a story that I can't tell. I don't see patients. Definitely, I'm not allowed to either. But I would just say I am always a fan of a provider that is willing to do policy work. You can educate all day long, and they will listen.
I'll piggyback off of that. I'm going to go back to my economics theme, because you're coming from an environment where you're dealing with very, very micro cases, and now you can effectively elevate those at a macro level when you're doing policy, because you've been the boots on the ground, you've been on the bedside. If and you're a nurse or a physician or whatever you've been, you've seen the conditions that not just the patients have to deal with, but your fellow healthcare providers have to deal with. And being able to take those experiences and then sort of expand them into a macro level, I think it has greater appreciation in terms of those who are trying to write the policy or influence the policy. It also, I think, is going to be far more effective than someone who is a talking head, a politician that is going to be, lack of a better term, having an anecdotal point of view on what's really going on. So I think my advice would be to use the experience as leverage, use that as collateral. That's something that you have in your toolkit that others don't. It gives you a lot more strength. But Also, we'll just kind of throw a mini warning out there, is that you also want to exercise that empathy, understand that there's going to be others that don't see it the same way you do. There are going to be others that have different incentives in this model. And that is one of the biggest challenges with our healthcare, in my mind, is the misalignment of incentives. And you have to understand where everyone is coming from and what are their incentives and what are they motivated by. And if you have that information, you have that knowledge in your back pocket, then you're able to not only effectively communicate, but more effectively influence others.
I'd like to add to what they both said, especially sort of coming from my legal background. And you would probably think legal and clinical, and how does that all sort of integrate into policy? And it's really interesting. I've got probably 7 or 8 health plan presidents that are physicians. I have had clinicians as leaders of the quality managed department. I've had leaders that are clinicians of the appeals and grievances department. The clinician brings so much to the table. And I think to what Susanne said in the beginning about do what you love, when you have that passion and you can go after it and you understand it and you are bringing the story to the table, it will come naturally. You will have to put in the time and the energy to learn the business. You'll, connect yourself with policymakers, connect yourself with lobbyists, connect yourself with areas of the organization where you work, maybe want to work, seek a mentor. There are things that you will bring to the table that I will not understand. I could try to speak to some clinical things, probably not a good idea. But the clinicians that, when we look at what the clinical team is bringing to our space, even our commercials are our nurse case managers. They're the ones saying, this member had this issue and this is how we solved for it. When we are going to bid in a state for an RFP, they're the ones, it's usually the clinicians that are telling the story. When we do our business operation reviews between corporate and the health plan, they start with the story. They always start with the member story. And that is what sets the stage. And so, I think to what Lindsey and Mike said, have the compassion, have the passion, and try to look at what you want to do and how does it integrate with the world that we're in, because it isn't the same that it used to be.
Again, terrific advice. And this aligns too. We had another question that was, how can social work students transfer their skills into the field of policy? Again, there's that key word that I'm hearing in everyone's narrative is, first of all, that transferring those skills, telling your narrative. How do the things that you are already steeped in, how can you use those as leverage and then gain some of that knowledge from other places? Again, how do you gain a little bit of that, business acumen? How do you gain some of the policy knowledge? I heard some great advice, networking, have some coffee chats, get to know people that are in those spaces. What are those key words? What's happening that you need to know? And then how can you kind of bring in your story there? So again, too, great advice on that round that can be, I think, delegated to any transferable, like either a clinician, social work, law, something that students always say that I can't connect the two. Yes, you can. You just have to think about how to transfer those skills to do to kind of get you where you want to go. Or sometimes you got to find out, is that really where I want to go? So talk to a lot of people. The mentor idea is really fantastic. So I'm going to put it out there to the live folks that are out here in our audience. If we have any specific questions that we'd like to ask while we have these wonderful guests with us. Again, too, there should be a little digital hand, or you can just unmute if that's not working out for you.
I can't find the hand function. So,
Sure. Dahlia, go ahead.
if I could just thank you. Thank you all so much for being here. I have a quick question. I know you all are talking about storytelling, and I know that's a huge part of, being able, like, being a persuasive and influencer, like just a leader who can tell a story well. So I was wondering what you found as the most important component to effective storytelling.
I'll just make it very quick. Know your audience and know your shit. Excuse my French. Just understand the domain, the subject, and we talked about statistics, have statistics, because those are the things that are going to be your hooks, right? If you have the facts, you have objective facts, you have objective statistics, those are going to be your hooks. And that's when you have an audience that is going to be captive. And again, understanding your room, knowing what motivates them, because that's going to help you kick off whether it's your presentation, speech, whatever it may be. That would be the advice that I have, is know the audience, understand what motivates them, and do as much background and research on the topic. So not only can you understand, or answer questions and respond to any doubters, but also right off the bat, just come across as someone who is very knowledgeable in the subject matter.
I'd like to add one thing: practice. Like, walk around your house, call your friends and practice what you would say, have your elevator speech. I remember being in law school and being in moot court, and I would just walk around and practice my opening argument. I would just, like, you should know it. You should be able to talk about it in your sleep. Somebody should be able to ask you a question. It should come so naturally, like, what is your favorite ice cream, right? It should come naturally. And I think the natural storytelling and knowing your audience, eye contact, pauses, thoughtfulness, and reading the room. I think reading the room to see if you're sort of going down the right path, or people shaking their head, or people falling asleep, are they looking at your phone? That kind of stuff, I think, will take your story where you want it to go.
Yeah, and depending, I'll even add on to that, on to what Mike and Amy have said, knowing your audience. I think please just write that down somewhere now. Always know your audience, know the language you're using. Again, from someone who's lived in the South, the Midwest, the North. As a child, I got made fun of because I always called a sugar sweetened beverage the wrong thing. It was soda, pop, or Coke, and whatever. Children knew exactly which state I was not from because I would say it incorrectly. But a story, you want to start with a hook. I think that was already mentioned. You want to have a middle, and then you want to always circle back to an end. And hopefully that end ties in a theme of either a pitch or what you are trying to either advocate, educate. What is my ask here, and how do I tie that in? I do remember, I think sometimes, again, knowing the audience and seeing their language, I'll say this because, it was a teachable moment. I was trying to talk with a staffer about school nutrition guidelines, and we were talking about the next Child Nutrition Reauthorization Act, which has not happened since 2010. It's supposed to happen every 5 years, but it hasn't. I had all my research, I have my statistics, blah, blah, blah. I could clearly see she got out her phone. She's starting to check messages. And I'm like, oh, I am losing this woman. And so I said, well, and one trick that I've used with my nephew who hates broccoli, and all of a sudden she stops and she said, my son hates broccoli. What's your trick? she could care less about what my report said, what the nutrition standards said. All she wanted to know is, how do I get my son to eat broccoli? And so literally we had a 5-minute discussion of how we incorporated healthier foods with, more comfort-based foods and foods that would, ease into a child's nutrition or appetite. And I, again, know that audience and know exactly when you've lost them, because how do you reel them back in and have those strategies? I love the practice strategies, because I try to say, if I lose them here, how do I bring them back in? If I lose them later down the road, how do I bring them back in? But again, what's your beginning, middle, and how do you tie that back to the end?
Thanks all.
Terrific. Thank you so much. Let's see, we have one question about the very popular value-based care. So with on value-based care and value-based purchasing among payers and healthcare organizations, I am wondering each of your perspectives on this and the impact this may have on your specific fields.
Mike, why don't you go first?
I knew you were going to say that. I got off mute as you were saying that. Yeah, I've done a lot of value-based care, and if you read my LinkedIn header, it says value-based care evangelist, and I truly consider myself one. I've been involved in it since its inception, at least on sort of the Medicare Medicaid side, back in 2012 with the inception of the ACA, Affordable Care Act. There's a lot of confusion right now around value-based care because the definition has broadened. And I think there's a lot of various types of applications out there. In my mind, that's a good thing, because it says that folks have actually learned from the concept of value-based care when it was very, very simple, when it was just accountable care organizations, and they have evolved the model and they have expanded it into other areas. So there's a lot of growth opportunities still out there, and the innovation and the evolution still continues. You have primary care first models, you have cardiologist groups that are taking risk from payers, same thing with oncology. So you have various models that are just being implemented even outside the government. To me, that's a positive sign that this is moving in the right direction. Where you will hear a lot of the naysayers is that you're not seeing the results that you did from some of the programs like the earlier ACOs, the bundle payment program, so on and so forth. And I'll give you my perspective on that. Largely the reason is because half of the participants got into those programs for the wrong reasons, and they got into it just to make money. And the easiest way to make money is what I call arbitrage opportunity. That's basically by doing nothing because the provider organizations around me are doing worse than I am, I'm going to actually make money because they're setting the benchmarks and my performance is automatically better. So by doing nothing, I'm going to make money. That is a very, very short-sighted and short-term strategy. It's going to last year, maybe two, because up until some point, you're going to see that gravitation toward the mean, and those opportunities are going to be gone. And if you haven't done anything to change care pathways, implemented tools to actually do total population health management, you're not going to succeed. So a lot of the doubts that you hear about value-based care, unfortunately, has to do with organizations that kind of came in, they took a bite out of the apple, and then once it became hard, they exited. I think value-based care is here to stay. It's not going anywhere. There is a lot of complexity around it, but I think that complexity creates even more opportunity. It creates opportunity for innovation. It creates opportunity for us to think differently and continue to improve healthcare.
Thanks, Mike. That's helpful. I say that because value-based care has evolved so much since the ACA was passed, and in my Medicaid world, it is so complicated. There are so many times, unfortunately, every time we want to put an initiative through that would be a value-based care program that would take statistics, that would be able to show, here's what we did on the commercial side, here's what we've seen on the Medicare side. and we try to put it through to the state for Medicaid approval, we often get kicked back. Well, we believe that's going to impact the Medicaid members' access to care because you're limiting the network. We believe that if you are providing care and you're getting this in return, the member may not get the care that they are looking for or what they want. We get so much pushback from a regulatory perspective. It is so difficult to push the initiative through. I'm sure you've seen this with some of your clients, but trying to get some of those approvals on a Medicaid, Medicare side, you sort of lose the intent, and where we started and then where we ended up is something totally different. And is it sort of a win-win? Maybe in the regulator's eyes. What I always wonder with the regulators is, are you truly looking at the best interest of the member? Like I am, but I am also a publicly traded company, and right, we have to make money. We got to speak to Wall Street. But why are you holding me back? Right? So are you doing it because you're looking at the letter of the law and forgetting the intent, where you should be my partner? And so the unfortunate realization on the Medicaid side in my world is it's extremely difficult to get some initiatives through that I would love to see.
If I could just chime in quickly and just add to that, that really is an underlying theme, or an overarching theme rather, with healthcare policy in general. I think that back and forth is something you're going to see across the board. I mean, it was the key arguments around the ACA and how the law was, amended over and over, and effectively by the time it was passed, it looked nothing like it intended to be. That's something we just have to understand are table stakes in healthcare and policy. And so when we think about application of programs, it trickles its way down into those programs and effectively everything that you do within the healthcare industry. And, we can speak to it from a compliance standpoint, regulatory standpoint, operations, so on and so forth. It's always going to be there. And it's a necessary evil that we have to go through.
I don't think I can add too much more to that, but except, two things. One, I also see continuously value-based care being done in different ways, at least with our capstone projects and, potential business plans. I'm always amazed at different models people or organizations are trying to attempt. And then after working, I only work on safety net programs. I only work with underserved or low-income populations. And I will also say that I am always amazed at I can show a policymaker or even explain to a policymaker, this is actually better for the individual. It's more convenient. It's, actually you're reducing a bunch of barriers and challenges of going 10 different places versus just one visit one time, or can I just call one number and be connected? Or is this connected, with electronic, medical records, EHRs. And I think I always make the joke, no one likes a lobbyist until they're on your side. I just think we need to know how to really, I stand by that statement.
Same way about lawyers.
I've never used that for lawyers, but I've always wanted to get a law degree. So we'll see after the session. But I just really encourage you to continue to know who your client is, who the patient is, who the population is, and continue pushing. And if you have to name it I hate to say it, if you have to name it or call it a different thing, so be it. It'll be in the contract and the writing, but for that conversation, know what language to use.
Susanne, can I bring up something about language, just generally about healthcare?
Sure.
Just, you guys probably know this, but especially, for people that may be coming into the industry, we love acronyms. Like, we love acronyms to no end. You will see more acronyms than you will ever know what to do with. Some organizations do have acronym books. Some do not. Most probably do not. you will learn them. It may be hard, ask around, write them down, but don't let them scare you. I just want to say that because when I started in healthcare, I could not believe that I couldn't even follow a conversation. And I was like, what did what to who to what? There were just so many. And so don't let that scare you away. Just write them down and there will be people to help you understand them. And we have Google today. Although,
yeah, absolutely. I was just going to say that, I've been in 3 industries where acronyms are just rampant, right? The military, information technology, and healthcare. And healthcare trumps them all. I mean, by a large margin. There's a lot of them. And I love the advice, Amy, don't be intimidated. Google it. No one knows all of them, and if someone is trying to sound smart and then throw a bunch of these at you, don't be intimidated. Just pause and say, not familiar with that one. Can you tell me what that means?
Yep. And how does it fit in, right? I mean, I'll tell you, I've been at my job 6 months and we've got systems and acronyms of systems, and somebody will be like, well, this rolls up to this and we need your approval to change the name of this system to this. And I was like, what are we talking about? What is this? And what is this? And why do we want to do, let's start from the beginning. And I know they were probably all looking at me like, who is this girl? I don't care, right? If you want me to be able to help you, I need to understand. And in order to understand, we need to have a conversation. And so I was like, let's get on the phone. Give me 15 minutes of your time. And once they explained it to me, I was like, okay. I drew myself, you guys can see my whiteboard. I drew myself a little chart. I was like, okay, now I know. And then I was like, oh, okay, now I understand what the question is. And I was able to ask my questions to give them an appropriate answer. So don't be afraid.
Great
Sorry.
advice. Oh no, we've had some big conversations about the language of healthcare. And also, as folks that will be in healthcare, be good stewards as well. So when you are talking, just as Lindsey said, know your audience. Make sure you're not using all of those acronyms without explaining. You don't have to be secretive, but that's part of access and equity, is really so people can understand what you're talking about. So again, don't be scared of them, but be really good stewards of language as well. I am going to, let's see, we've got 3 minutes left, and let's see if you guys could each take a minute, because this question really excites me, is what do you see the direction of that your industry, company, organization is moving, and what excites you about the future of healthcare, the healthcare industry, especially in your area?
I will start quickly. I gotta say that the expansion of Medicaid, for me personally, it's a passion for me to see the underserved, and there was a whole middle section of people that just didn't have access to care. And so the expansion of Medicaid in certain states like North Carolina, and continuing sort of expanding what may be available to people is so endearing to me. I have been fortunate. I've had a good life. I've been provided for. I can afford it. But there's so many people that they don't even have the chance. And so for me to see that Medicaid expansion and to hopefully continue to support it is going to be challenging, but I think it's going to be amazing.
Mike or Lindsey?
Yeah, I will say, yes, I look forward to seeing North Carolina's Medicaid program, hopefully starting soon, in a few months. Knock on wood. I think this desk is made of wood, but I would also say, just in general, in my world, when I talked about, I kind of sit at the table between, nutrition, food, and then also healthcare, is this food as medicine movement. So again, for those that still may not qualify or may be underinsured and uninsured, and I can't get you to a doctor, can I make food affordable? Can I make it easily accessible? Food insecurity impacts chronic disease. Obesity impacts chronic disease in just so many ways that really put wear and tear on our healthcare system. So I'm excited about that. And to be honest, I came back, like I said, I came back to UNC because I wanted to see what our next public health leaders can do. So actually, I'm actually looking at you all in the room, and I'm excited to see what you all are going to do and what you can do in this space for the next, 20, 30, 40, 50 years. I mean, I don't know if I'll ever retire, so maybe I'll see you there in 50 years, but I might have done the math a little bit too nice. Not 50 years, but I'll look forward maybe in 30 years to see where we all are.
Awesome. And Mike, send us out.
Lindsey, thank you for mentioning that, because what I had reserved for this question is social determinants of health, and no longer just looking at the clinical profile of a patient to better serve them. And this is a movement that started sort of as a hashtag, and it's been a buzzword that people have been using over the last 5 to 6 years, but it's starting to get some legs right now. And there's organizations that are really doing some really great things about addressing those non-clinical gaps for patient, because as we mentioned, food insecurities, that's going to lead to diabetes, right? Just to give one example. But things like housing, access to medication, getting rights to your appointment, how much is that costing us in healthcare? Because individuals can't access healthcare because they can't get their medication. And then the other side of that is all of the modeling that we do in healthcare has to do with previous healthcare trends and utilization patterns. And that is just, it's a self-fulfilling prophecy. We're saying things were so screwed up back then, we're going to continue to make them screwed up because we're using the past to predict the future. And bringing social determinants of health and bringing that data in, I think, is going to start to improve the models and start to take it in a different path and allow us to be more proactive and truly become managers of total population health, and be able to finally get in front of a lot of these exacerbating issues that are just, they're killing the outcomes and increasing cost of care.
Again, it's a little after 7, so thank you, audience, for hanging on. But first of all, thanks for the many people who attended tonight. This was an exciting conversation, and a special thank you to Amy, Mike, and Lindsey. This was fabulous. So again, reach out to these folks on LinkedIn, access their profiles and take a look, and also reach out to other folks like them, because that's where you're going to really gain that critical information you need to move forward in the field. But again, thanks for your time. Everybody have a great night, and hopefully we'll see you at our healthcare conference on November 3rd. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you.
Go Heels.
Bye.